Here at the Union World Conference on Lung Health, delegates have been hearing about the double burden of TB with diabetes. The issues raised are both clinical and organisational. I'm here in Barcelona at the Union World Conference on Lung Health with Anil Kapur. Anil, you're director of the World Diabetes Foundation. Now, you've highlighted an important problem here in that diabetes and TB go together. What is it that you've uncovered?
Well, this is something that has been known for centuries. In the ancient times, both diabetes and tuberculosis, the coexistence has been described. And even back 70 years back, in Europe, there used to be clinics for diabetes and tuberculosis. But the thing is that we have forgotten about this comorbidity because when in Europe there was still tuberculosis around and diabetes was emerging as a health problem, there used to be these clinics together. And it used to be said that if people didn't die of diabetic coma, they would die of tuberculosis.
So in the battle against TB, you're urging screening for non-communicable diseases as well as TB screening.
What we're urging is a more holistic approach to healthcare delivery at the primary care level. For far too long, we have worked in silos. And diabetes, the rise of diabetes and the interaction with tuberculosis actually provides us an opportunity for creating a more integrated approach to healthcare prevention and delivery at the primary care level. Because one of the issues with diabetes has been that it is underfunded, it's very clinical, and there's no public health approach to it.
Generally speaking, we've assumed that TB is a disease of the poor and diabetes a disease of the rich, but this isn't necessarily so, is it?
That is not necessarily the case. I think that is a myth that has been busted very convincingly. Just to give you some of the figures, globally we talk of about 382 million people with diabetes. 80% of these people live in the developing countries, in the low income and middle income countries. And if you look at the top 10 countries with the highest burden of diabetes, these are China, India, Indonesia, Pakistan, Bangladesh, Nigeria, Russia.
So now you're urging bi-directional screening, as it's called. What do you mean by that?
What we're urging is that if one of the problems is that many times people with the most common variety of diabetes, which is type 2 diabetes, the symptoms are very vague. Often a feeling of tiredness, or they might have loss of weight, or not just feeling well, and sometimes even the tendency of a malaise or something like that. Now, these are also some of the symptoms that people with tuberculosis in the initial stages may have. So the issue is that if you have diabetes and that gets diagnosed first, the clinicians don't worry that we need to also look at whether the person might have tuberculosis. The same is the case the other way around. So if you pick up tuberculosis first, then you don't screen them for diabetes. But the fact is that people with diabetes are at 3 times higher risk of getting active TB disease. And if we screen people with diabetes for tuberculosis, we will pick these people who might otherwise remain undiagnosed for a longer period of time and remain infective. On the other hand, we have a large pool of people with diabetes who are undiagnosed in the developing world. So if you start screening people with tuberculosis, you'll pick up these undiagnosed cases.
So can you give me some idea of the size of the problem of these missing patients who have one disease, the other, or both?
If you look at the case of diabetes, we say that globally almost about half of the people with diabetes, estimated number of people with diabetes, don't know that they have diabetes and are picked up when they are actively screened. This number may be much higher in many of the developing countries like China, India. In fact, one of the studies done and was reported, I think, 2 years back in JAMA, where showed that in China there are 114 million people with diabetes estimated, but only 40% of them are diagnosed. So the numbers are quite huge. In case of tuberculosis, we believe that there are approximately 30% of cases of tuberculosis who are not picked up at the right time.
Inevitably, this is a team approach and there needs to be national policy. So what do you urge to be done now?
What we urge is that first the people responsible for healthcare delivery and for health policy should recognize that the comorbidity of diabetes and TB is a major threat for the control of tuberculosis going forward. That we need to address this burden in a manner where we need to create awareness amongst the clinicians, both in the people who are treating tuberculosis as well as people treating diabetes, that this is a real issue, that they need to screen for the two conditions, particularly in countries where tuberculosis is a high burden issue. In those cases, we urge that every case of diabetes should also be symptomatically screened for tuberculosis, but we urge that everywhere in the world, people with tuberculosis must be screened for undiagnosed diabetes.
This could fall between two different areas because diabetes is looked after by doctors, clinicians, whereas a community approach is needed for TB. How do you solve that problem?
I think a bit of public health approach to diabetes is required. Unfortunately, it is too much of clinic-based, and result of that is that we don't even have data in many countries around the world as to how many people with diabetes exist in a clinic, how often do they come, how often they don't. I think that approach from the tuberculosis world would actually help and benefit the care of people with diabetes. So we have been actually promoting an approach which borrows from the DOT strategy of tuberculosis to be applied to delivery of care for diabetes and hypertension, because that would actually create a system where we might be able to gauge exactly what's happening to these patients.
So how would you sum up what needs to be done to tackle the double burden of TB and diabetes?
I think I would first of all urge through you and the rest of the media to make it publicly aware that this is a burden that is a big issue and would continue to grow if we don't address it. The next important step is for policy planners to start taking an initiative to address training and awareness building in the healthcare system, both on the side of tuberculosis and on the side of the diabetes world, of the two diseases coexisting and sometimes complicating the problems. And thirdly, to start implementing a program where at the primary healthcare level, it may not happen at the specialized centers, but at the primary healthcare level, it is possible to actually create programs that would address the double burden of diabetes and tuberculosis, both from a preventive side as well as treatment side.
So how would you sum up in 10 or 15 seconds what doctors, other healthcare practitioners and governments indeed need to do about this?
The key message would be that if you identify a case of tuberculosis, particularly if the person is elderly, has a family history of diabetes, please screen them for diabetes. You'd be amazed at the number of new cases of diabetes you'll pick up. On the other hand, people working in the diabetes world, keep your eyes open to the fact that a person with uncontrolled diabetes may actually be having tuberculosis, and please look out for it and screen them.
And the potential for saving life is quite considerable.
It's immense, it's huge.
Anil Kapur, thank you very much.
Thank you.